Biliary system. First, we start with the anatomy of the biliary tree. This schematic illustration of intrahepatic and extrahepatic biliary tree. The biliary tree formed by the right and left common hepatic duct. The right hepatic duct receives the bile drainage from the right lobe. So it has two ducts, the right anterior, which received from the anterior lobe, the segment 5 and segment 8, and the right posterior, which received from the posterior lobes, segment 6 and segment 7. They both unite to form the right hepatic duct. The same occurs with the left hepatic duct, which received from segment 2, 3, and 4. Both ducts unite to form the common hepatic duct, which runs anterior to the portal vein. After that, after about 3 centimeters, it joins the cystic duct to form the common bile duct. The common bile duct has 3 parts, a supraduodenal, a retroduodenal, and infraduodenal or pancreatic parts. The last part is joined by the main pancreatic duct and open at a common opening at the second part of the duodenum at ampulla of water. This MRI view illustrates the same thing. We can see here the right anterior and right posterior hepatic duct joining together to form the right main hepatic duct, which unite with the left hepatic duct to form the common hepatic duct. The common hepatic duct receives the cystic duct to form the common bile duct, which open at the second part of duodenum. We said that the common bile duct has a 3-part supraduodenal, retroduodenal, and infraduodenal or pancreatic part, which receive the main pancreatic duct and open at the second part of duodenum. The intrahepatic bile ducts, this all have been mentioned. It's worth to say that the bile duct draining the caudate loop, it joins either the right or the left hepatic duct. It has no fixed drainage. The common hepatic duct, as we said, it lies anterior to the portal vein. Its mean diameter is 3 millimeters. However, it varies with the age and increase in diameter with increasing age. The cystic duct drain the gallbladder and join the common hepatic duct. It's about 3.5 centimeters in length and about 3 millimeters in diameter. It lies anterior to the cystic artery. Here we can see the cystic duct. This is the cystic duct joining the common hepatic duct. The common bile duct, about 8 centimeters in length, and average diameter is less than 6 millimeters. After over than 6 millimeters, it is regarded pathological. However, it can be more than 6 millimeters in a normal person, either at increasing the age or after cholecystectomy. Regarding the age, we can consider the upper limits is 1/10 the age of the subject in millimeter. For example, if the patient's age is 80 years old, so up to 8 millimeters is accepted. The common bile ducts join the main pancreatic duct and open at the second part of the duodenum as at ampulla of water. The gallbladder is a pear shape. It consists of a fundus, a body, and a neck. The main length, when the gallbladder is distended, the main length is 10 centimeter, maximum 10 centimeter, and the width is 3 centimeter, and the wall thickness is 3 millimeter. Anatomic relationship. This is the gallbladder. We can see that anterosuperiorly is the liver and the anterior abdominal wall, while posterior-inferiorly, the lesser omentum, which connects the stomach to the liver, the lesser omentum, the first part of the duodenum, and the transverse colon, all located posterior-inferiorly to the gallbladder. The gallbladder shape, this is the normal pear-shaped gallbladder. It may have an elongated shape or S-shaped gallbladder. Sometimes the fundus is folded over itself to form what is called a pharyngeal cup. The gallbladder variants. We have variants regarding morphology, regarding number, and regarding position. This is the typical pear-shaped gallbladder. We may have a single septum in the gallbladder or multiple septa in the gallbladder, as we see here. Pharyngeal cup, we said sometimes the fundus is folded over itself to form what's called a pharyngeal cup. This is also a pharyngeal cup. Diverticulum of the gallbladder. This is the ultrasound view, and this is a CT view demonstrating a diverticulum of the gallbladder. Regarding the position, we may have a suprahepatic gallbladder. This is ultrasound view, and in this CT view, we can see that the gallbladder located suprahepatic. Retrohepatic gallbladder located posteriorly. Here also the gallbladder is located posteriorly near to the right kidney. Intrahepatic gallbladder, which is normal in infants up to 2 months. Here we can see the gallbladder is surrounded by the liver on all sides. This is also the gallbladder, intrahepatic gallbladder. Here we can see a multiple gallbladder stone, and here intrahepatic gallbladder containing multiple stones. Regarding position, a left-sided gallbladder located under the left lobe. It may be due to herniation through epiploic foramen, or it may be a part of situs inversus. This is a left-sided gallbladder. We can see it is located under the left lobe of the liver. This is a left-sided gallbladder containing multiple stones. And this is a left-side gallbladder located in the left side as a part of situs inversus. Here we can see that the liver in the left and the spleen on the right side. Gallbladder duplication, which is an extremely rare variant. It may be either a partial or a complete duplication. Here we can see an ultrasound picture of duplicated gallbladder. This is also a duplicated gallbladder, and this is a CT picture of the duplicated gallbladder. There's a complete duplication. Regarding arterial supply of the gallbladder, it is from the cystic artery, which is a branch of the right hepatic artery. This is also another picture of the cystic artery, which is branching from the right hepatic artery. Variation in the biliary tree. This is the usual anatomy. This is the typical anatomy where the right anterior and right posterior duct unite to form the right hepatic duct. The right hepatic join the left to form the common hepatic duct. This is the typical anatomy. The most common variant is where the right posterior duct join the left hepatic rather than the right anterior duct. Another variant is where all the right anterior, the right posterior, and the left hepatic join together to form the common hepatic, and less commonly, the right anterior duct joining the left hepatic duct, and after that, the right posterior join them in a common channel to form the common hepatic duct. We may have a double hepatic duct, where the right and left hepatic ducts may fail to unite. Here we can see the right and the left hepatic duct fail to unite and continue as a separate duct to join the cystic duct, and lastly forming the common bile duct. So here we don't have a common bile duct, a common hepatic duct. We have a two separate right and left hepatic duct joining the cystic duct to form the common bile duct. Another variant is an accessory hepatic duct, which usually arise from the right lobe. Here we can see an accessory duct joining the common hepatic. Here it's joined the cystic duct. Here it joined the common bile duct. Here an accessory duct is joined the gallbladder directly, and here we have two accessory hepatic ducts. Variation in the CBD. The CBD, it has to unite with the pancreatic duct and after that open in the second part of duodenum. Here we can see that the common opening or the common channel is very short. Here the common channel is very long. It is more than 15 millimeter. And this variant where the common bile duct and the pancreatic duct continue without uniting and open separately in the second part of the duodenum. After anatomy, we will start the radiological imaging of the biliary system. We have a plain film, ultrasound, contrast examination, MRCB, CT, ERCB, and scintigraphy or technetium hydroscan. Regarding the plain film role in the imaging of the biliary tree, the only role is to see the calcification and gas inside the biliary tree. Here we can see a gallbladder stone, multiple gallbladder stone. Here we can see a gas inside the biliary system, which is called pneumobilia. The presence of gas inside the biliary system, it is pathological, unless in this situation, first in the elderly where the ampullary tone is low, and this permits a duodenal gas to enter inside the CBD and to the distal biliary tree. Or after sphincterotomy or after surgical anastomosis of the bile duct small bowel, like in cholecystectomy. Here we can see a calcification in the wall of gallbladder, which is called a porcelain gallbladder. Here we can see gas inside the wall and inside a lumen of the gallbladder. This is a case of emphysematous cholecystitis. It's very important to differentiate between pneumobilia, which is the presence of gas inside the biliary tree, and presence of gas inside the portal system. Regarding the pneumobilia, the gas, it has a wide diameter. It is centrally located and branching in nature, while in the portal, it reaches the more peripheral part and it has a narrow diameter. Second, we have the ultrasound. The ultrasound can visualize the gallbladder, the intrahepatic biliary duct, and extrahepatic biliary duct. However, the distal part of CBD is usually obscured by gas. Here we can see the normal gallbladder. This is a case of cholecystitis. We can see thickening in the wall of gallbladder with pericholecystic edema. Here we can see an intrahepatic biliary dilatation, which has a serpentine appearance. يعني متعرجة تصير. Contrast examination. Contrast, we have intravenous or oral cholecystography. They both have been replaced by ultrasound. We have intraoperative cholangiography, T-tube cholangiography, PTC, and ERCB. They all have been replaced by MRCB. First, intravenous and oral cholecystography is by giving the patient an oral or intravenous contrast that outline the biliary tree. And after that, the biliary tree is imaged with a plain film. Here we can see that the biliary tree is outlined by the contrast. Here also the biliary tree is outlined by the contrast. The PTC is by placing a tube from the external surface, from the skin, and puncturing the biliary tree, and after that a contrast is given to outline the biliary tree. The PTC is nowadays only reserved for therapeutic cases where ERCB cannot be done. So in order to get rid of bile, in order to drain the bile and prevent the development of jaundice, the PTC is done. Intraoperative cholangiography, we can do during laparotomy or laparoscopy. A tube is inserted inside the biliary tree and a dye is given to outline the biliary tree completely. Here we can see the right and the anterior and posterior right hepatic, the left hepatic, and the common, joining the cystic duct to form the common bile duct. T-tube cholangiography. After cholecystectomy, here we can see there is no gallbladder. So after cholecystectomy, when there is a suspicion of remaining stone, we put a T-tube. The short arms of the T is placed inside the common hepatic duct, and the long arm is placed externally, or external the body. The function of this to allow the passage of small stone inside the short arm, and also allow the passage of the bile outside the body in order to prevent the development of jaundice. ERCB, it is replaced by MRCB. The only role of ERCB, or it is only reserved for therapeutic cases. This is the main endoscopy, which is passed from the stomach to the duodenum. And here the contrast is given. Here we can see the biliary sphincter, the common bile duct. This is the cystic duct, and this is the common hepatic duct, the right and left hepatic duct. The MRCB, it is excellent image of biliary system replacing the ERCB. It uses heavily T-weighted fast suppressed sequence. So the static fluid will appear hyper intense on a background of a signal void. Here we can see the intrahepatic biliary duct. This is the right and left hepatic duct, the common hepatic duct. This is the cystic duct, joining the common hepatic to form the common bile duct. This is the main pancreatic duct, joining the common bile duct and open at the second part of the duodenum. Here also, this is the gallbladder. These the left, the right, and left hepatic duct forming the common hepatic duct. and after joining the pancreas, the cystic duct, it formed the common bile duct, which drain in the duodenum. This is a case of Cbd stone. We can see there is dilatation of the whole common bile duct with a rounded signal void structure in the distal part. This is a case of Cbd stone. This is also a Cbd stone where there is a dilatation of the total Cbd. Also, the intrahepatic bile duct is dilated, and there is a signal void structure in the distal part of Cbd. CT of the biliary tree. During imaging the biliary tree, we use a IV contrast enhanced CT. So the biliary tree will appear as a low density linear structure. Here we can see the biliary tree because it does not take the contrast. We can see the CBD and the common hepatic and the CBD anterior to the portal vein. This is the gallbladder. Lastly, CT cholangiography. In CT cholangiography, we give a contrast that outlines the gallbladder. IV contrast, such as sodium iotrixate, it will outline the biliary tree. And after 30 minutes, a CT scan is performed. Here we can see this is the biliary tree is completely outlined by the contrast, the right and left hepatic duct forming the common and joining the cystic duct to form the common bile duct. Lastly, scintigraphy or HIDA scan. It's used mainly in a neonate to differentiate between biliary atresia and neonatal hepatitis, because this agent is accumulated in the liver and excreted in the duodenum. So failure of excretion after 45 minutes, it means that we have a case of biliary atresia. While fail or delay of accumulation of the contrast in the liver, it means that we have a neonatal hepatitis. استاذ نبدا بالكويز.
يلا متى يقلب زين هاي من الموبايل مو الايباد؟
من اللابتوب دكتور.
من اللابتوب. زين هذا شنو باوربوينت؟
نعم.
شو مدى احس السلايدات تقلب مثل هذه على كل. اذا هسه نروح على الكويز. نبدا بدكتور عماد.
نعم استاذ. This is an ERCP study. ERCP study. رقم 1 is the endoscope itself.
This is the endoscope itself. دكتورة فرح زهير.
نعم أستاذ. رقم 2 البنكرياتيك داكت.
بنكرياتيك داكت. لها اسم؟
المين بنكرياتيك داكت.
مين بنكرياتيك. رقم 3 الدكتور عزام.
نعم أستاذ. هاي common hepatic duct.
This is the common hepatic duct. دكتورة سؤدد رقم 4.
نعم أستاذ. This is the cystic duct.
صحيح. رغد سعدون رقم 5.
نعم أستاذ. left hepatic duct.
left hepatic duct. أحمد ماجد إبراهيم.
نعم أستاذ. right hepatic duct.
right hepatic. وأخير واحدة إيمان فلاح موسى.
نعم أستاذ. رقم 7.
رقم 6. 6 قلنا الرايت. رقم 7 الجول بلادر. اي رقم 8 اكو بعد و9 8
نعم.
وين؟ ورا ايمان زاهد.
نعم دكتور. ستومك هاي دكتور يعني. ستومك دكتور.
ايش احنا نقول ستومك هاي يعني الستومك
يعني الجهاز الاستومك.
جاشريك اير بابل. لازم تكونون دقيقين بالتعبير لان احنا هاي مو ستومك، هذا غاز ريجن. بابا دائما تكونون دقيقين بالهذا. رؤى باسم اخير واحده 9.
نعم دكتور. هذا الغاز عند دودنا.
اكسلنت. هذا الغاز عند دودنا. حتى تقدروا تقولون غاز شادو. بقيت رقم 10 زينة عبد الجبار.
Right hemidiaphragm.
Right hemidiaphragm. Excellent. اوكي ها ماكو بس هذا يلا